We touched on these a little bit. So there's multiple different types of trials, right? We have the trials that are and they're classified differently by different classification thinking. So by design, by how they were randomized, by the type of intervention there were, by the setting, by the disease that they were looking at, and by the stages that people were doing. So we'll try to go over this in this session. So all of us are familiar with the basic design. We call it this is a 2-arm, but it could be 3-arm or 4-arm. The basic one is 2-arm and parallel. Parallel means that the interventions are given at the same time in the patients. So we've got a target population, and then from those we select those that are consenting eligible. And these are the people that are, as I call, the garbage sample, the people that saw the advertisement on the bus, those that a friend told them, oh, why don't you join this study? The doctor convinced them, oh, you should do this study. All sorts of reasons, non-probability reasons. So then we get them, we randomize to the intervention, A or B, and we follow them and observe the event in a time. Standard, this is what is known everywhere as the basic 2-arm parallel designed for a clinical trial. We can do it 3-arm, as in this study that was the management of mild to moderate symptoms of COVID that was done in India. I don't know if there's a name of the study. They were looking at 2 polyherbal concoctions and with standard allopathy treatment on it. So they had arm 1 was the standard allopathy with placebo. Arm 2 was standard allopathy with this nilavembucudanir, and the other one was standard allopathy with cabazitacudanir. So this is, again, 3-arm parallel, very commonly done. You're trying to show superiority of the usually, or you could do non-inferiority of one to the other, etc. So separate out the design from the hypothesis. You can do a parallel study that is a superiority one. You can do a parallel study that's non-inferiority, for example. But this is what is a 3-arm example. Crossover design is another one that is fairly enticing to use because now we randomize to intervention A or B, we observe the event, and when after a period of washout, we now, people that got A before, get B afterwards, people that got B before get A afterwards, and we observe them there. The advantages here is that if I have 100 people that are randomized, I have 50 and 50, I have now 100 people that got A and 100 people that got B, so I've doubled my sample size. And people say, wow, this is fantastic. I should always do crossover studies. No, these are very difficult to do. Why? For multiple reasons. Because if I'm doing a study where the event is death, I cannot resurrect people and do it again. Unless one of you is God, that doesn't happen. So we cannot do terminal events. If the event is a chronic disease event, like cancer in remission for 5 years, now the study is taken 10 years. If the medication has latent effects, it stays in your body for a while, then you have a long washout period, so that extends everything. If the intervention is not taking a medication, but it is changing behavior, where I teach you something, or you're supposed to do this way, now I have to unteach you that. We can't do that. So this, while it sounds very attractive, it's very, very difficult to do. It's not that commonly done. So it has these advantages that can lead to increased precision and efficiency because the subject is their own control. And if we don't have any carryover effect, it is more efficient. It can also help recruitment because I can tell people, oh, everybody's going to get the new intervention. Some of you will get it first, some of you will get it later, but everybody's going to get it. So then people will join your trial. But the carryover effects are the main problem. Okay. We sometimes do incomplete crossover design, and this is done because sometimes once you get the intervention, you cannot unlearn things. You just get some people to get the intervention later than others so that you can compare two things. You can answer two questions. You can answer what is the effect of the intervention at this point, or if I compare the effect of the intervention here to the effect of the intervention here, I can look at delayed intervention versus non-delayed intervention. So people do this incomplete crossover sometimes. Again, it takes a long time because I forgot to put the washout period here. So there should be a washout period as well. And it takes a longer time. You don't get the benefit of the increased sample size on that. So some people do it, some people don't do it. Factorial design is a very attractive design. It's often used. We at our institute, we use it a lot. And what are we doing here? Now we have two different types of interventions that we want to use the same patients to answer both questions. Does this intervention A work? Yes or no? Does intervention B work? Yes or no? So the factorial design has some benefits, but also has some potential pitfalls. So what you do is your participants are randomized to either get only B and not A, or only A and not B, or get none of them, or get both of them. So what is the advantage of doing this? The advantage is if there is no synergistic effect. What is a synergistic effect? That's the common language term for interaction. Interaction statistically means that the effect of B depends on whether you get A or you don't get A. So if the effect of B is different for the people, the effect of B is this versus this. So the effect of B, if you don't get A, would be here, and the effect of B when you get A is here. If those two effects are the same, then I actually can ignore A and just look at double the sample size. And the same thing would happen if the effect of A does not depend on the effect of B, of whether you get B or not. Then I double the sample size and I answer two questions with the same folks. That's what the attraction is. But in the interest of, in the presence of interaction, then I don't get that benefit of the doubling of the sample size. And it allows me to answer what happens if you get both of them at the same time versus you get only one of them, right? And so it's, some people think of it as it's equivalent to a four-arm parallel design where you have the no, 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 yes, yes, no, and yes, yes people that you're following. Now, if there is no interaction, you get two studies for the price of one. If there is interaction, you get two studies for the price of two. You don't get any benefit from it. No, there is a way to test it. You would calculate the effect of B in the presence of A. You calculate the effect of B in the absence of A, and you test whether those are different or not. The effect of B does it vary by the presence, or there's a test for interaction that one can do. but it's not testing the yes, yes versus the yes, no. It's testing all four cells. Yeah, so the example is coming up in a second. Here. So this was a study that was done in Malawi. Um, um, this is an old study. Now the answer has been there. But at that time, when a mother was HIV positive, it already had been shown that giving antiretrovirals during pregnancy was of benefit to prevent the child being born with HIV. So you give antiretrovirals to the mother while she's pregnant. But after delivery, at that time, this was 2002. So in the year 2000, it was not known yet whether after the baby is born, the mother is breastfeeding. So should you continue to give antiretrovirals to the mother while she's breastfeeding? Or should you give antiretrovirals to the baby while the mother is breastfeeding? Or you don't do anything because the standard of care was to do nothing. So it's the one factor they wanted to look at was no ART, infant ART, or maternal antiretroviral. However, it was also known to these folks that these are very poor women that are nutritionally deficient, and they did not know whether nutritional supplement was helpful or in the effect of the antiretroviral. If you have nutritional supplement, is the effect of the antiretroviral better than if you don't get nutritional supplement? So they were interested in the joint effect, synergistic effect. So we had a 3x2 factorial design that they were looking at. It actually showed that antiretrovirals to the mother were better than to the child, if I remember correctly, and that with nutritional supplement, it was much better. So there was an interaction. So they do this. If there is no interaction, meaning that nutritional supplement, the effect of antiretroviral is the same, good or bad, is the same whether you get nutritional supplement or not, then you can answer both questions. Because then you would also see what is the effect of nutritional supplements, regardless of whether you give antiretrovirals, you answer that question. And then you answer the question, does antiretrovirals help whether you get supplement or not? As an anecdote, I'll mention that this was very interesting because the nutritional supplement was actually a little cookie that was enriched with all sorts of stuff, but it looked like a cookie. And unfortunately, in Malawi, if a wife has HIV, most likely the husband has HIV. And if they're poor, everybody's poor. They're nutritionally deficient, everybody's nutritionally deficient. And the husbands were horrible. They would sort of take away the cookie from the wife and eat it themselves because they're starving. So finally, they had to call it, they relabeled it, didn't call it nutritional supplement or anything. They called it study medication and packaged it as study medication so the husbands would not touch it. Anyway, but this is a 3x2 factorial. The issue is that you get the benefit of two studies in one if there is no interaction. If there is interaction, then you understand what are the synergistic effects. Does this one work better with this or without it, etc.? And you interpret it this way. Okay. So it's fairly popular. Mm-hmm. Yes. How would you get to 4? No, it's not any different. This is a 6-arm parallel. Same thing. So it's just you can visualize it whichever way. Most people present it like this. They don't present it this way because it takes more space in the paper. exactly the same thing. So it's a good question. We'll see tomorrow the sample size. So it depends on your question, right? Because you will calculate for this one, you will calculate a sample size for testing the nutritional supplement question. What is the effect of nutritional supplement question on their outcome of child getting HIV? And you will have an effect size that you expect. You have the variance in that effect, and you'll have how much you think is going to be, the signal to noise ratio. You put it in the formula, you get a number, whatever. Then you do another one for the other one. What is this infant ART versus no ART? You calculate the sample size for that. Then you do another maternal antiretrovirals versus no antiretrovirals. You get a sample size for that. Now you take the highest of all of those three so that you have enough for it. And it becomes an issue if one of them requires very little and the other one requires very lot. Now the very little one will be overpowered, and you may get a significant result for a meaningless effect. So you have to be careful with that, etc. So it's a little more complicated, but people like to complicate their lives by doing factorial designs. All right. Yeah, so you can do it stratified test. So in the presence of interaction, then you can do more interesting comparisons. You can compare the effect of B with no A, the effect of B with A is green, the effect of A with no B, or the effect of A with B, and you get that. But now you're having multiple testing. So I need to adjust for the fact that I'm doing multiple tests. Oh, and the tests are not independent. They're correlated. So then there's ways to correct for this. So yes, while the factorial design is attractive, if you have interaction, you get complications. And you don't know if you're going to get an interaction or not. In the Malawi study, they expected interaction, so they had planned for it. But many times people don't plan for it. A little bit more complicated factorial design is not very commonly done, but I found out that we at my institute in McMaster did this a while ago before I got there in 2018. They published it, but it already had stopped. So they randomized people to, this is looking at a poly pill, they call it the polycap, which is minute or non-therapeutic levels of different medications. One is a statin, one is a blood pressure lowering, and another is a anticoagulant, and one is a statin. There was 3 or 4 things mixed together. And they randomized people to polycap active or polycap placebo. But within each one of those, they had aspirin active or aspirin placebo. Within each one, they had vitamin D active or vitamin D placebo. So now they're testing a 3-way interaction, 3 or 2 by 2 by 2 factorial. So they're expecting to be able to answer 3 questions. Does vitamin D work? Yes or no? Does aspirin work? Yes or no? Does the polycap work? Yes or no? 3 questions in the same people if there is no interaction. And so some people do them. They're not very commonly done. But at our institute, the director, former director, Salim Yusuf, likes to do factorial designs. And so then there's multiple possibilities of reporting this. And they reported the, let's see if I remember correctly, which ones are these graphs here. Oh yeah, this is the effect of polypill versus placebo. This is aspirin versus placebo. And then this was the polypill and aspirin combination. Apparently, the vitamin D did not have an effect, so they didn't present it here. And they showed that the polypill was beneficial because the hazard ratio of first event of the primary outcome was lower in the polypill it was also, aspirin was also beneficial. And in the polypill plus aspirin is the green one, that was the better one. So here they're presenting the two marginal distributions or effects, and here they're presenting the 2 by 2. So they basically, since this does not show an effect, then they reported these four. So these four are the four lines that you see here as a four-arm parallel they reported. It's not commonly done, but it is, it's done somewhat. And this study is one of few studies that have been done with polypills. It showed that it works, but and it has an important effect, but it's still not something that is being marketed. And the reason it's not being marketed is purely economics, because to produce the pill, it's less than 1 rupee per pill. So no pharmaceutical company wants to produce it because they're not going to make any money. And so this is out there, but unfortunately, nothing is happening with it. Now, we talked a little bit about designing factorial designs. At the design stage, you have to have the sample size needs to be calculated. If you're going to have interaction and you want to test interactions, you should power for it. They become a little bit more difficult to be done. And at the analysis stage, you first have to assess interaction. And it's not whether it's statistically significant or not. The interaction, you look at it, is it a meaningful interaction? Now you'll ask me, what is meaningful? That's your personal choice. Your critical mind as an investigator, you decide if you think that is meaningful or not. And many people are afraid to give their opinion, and that's why they rely on statistical significance. But we know that statistical significance has nothing to do with importance or meaningfulness of a result. Because if you had not been able to recruit enough people, you would not have enough power to, even if you have a meaningful interaction, to say it is statistically significant. And just because you don't have a statistically significant interaction doesn't mean you don't have an interaction that's meaningful. And that's the risk here, is that people say, oh, it's not significant, I don't have to worry about it. That's not true, because you worry about it whether it's significant or not. You worry about it when it is meaningful. And again, that's a subjective term, and people need to be willing to say, in my opinion, I think this is important. And you put that in the paper and write the paper that way. So if meaningful interaction, then you say, oh, in the presence of B, A is this. In the absence of B, A is this. You report them separately. If it's not meaningful, then you get the benefits of answering 2 trials in 1. This is a study that we did, another factorial one in COVID, that was just recently published in Lancet Respiratory Medicine, where they were looking at colchicine versus control. And then they did rivaroxaban plus aspirin versus control as well. So they had a 2 by 2 factorial. So they had colchicine versus control and rivaroxaban plus aspirin versus control. Here they're giving you the full concert diagram with who was included and who was not, but basically it's a 2 by 2 factorial design. Now, this is an interesting one I was involved with. We have incomplete factorial. And why do we have sometimes incomplete factorial? It could be because the no may not be ethical to be done. Or the yes may be too problematic. If I'm doing drug A and drug B for the same condition, the pharmacist may say, you cannot give A and B together because this will cause trouble in the person, renal failure or whatever. So the yes may not be possible. In this case, it was the no. that was not sponsored. These were people that had functional bowel disease, and there's no good pathology for it. People say, oh, it's due to depression or anxiety or this or that. And so there is not a good, there's some treatment. Some people give drugs like the cypramine for depression. And there was a colleague who she was interested in cognitive behavioral therapy. And so they said, well, why don't we do a factorial, do the drug as well as the cognitive behavioral therapy, yes or no? Well, psychotherapy, active versus psychotherapy placebo is pretty unblinding. You know what you're getting, what you're not getting. They were given education. But the ethics board said, no, you cannot give placebo to people because these people have a problem of functional bowel disease. So they cut it off and said, no, the no does not go. If you want this trial, you need to do it this way. So we had an incomplete factorial design. All right. Any questions on the basic designs? We're going to talk about some other adaptive designs coming up later, but these are the three basic designs that we have. The analysis is not the factorial. The analysis is separate. The factorial is a design. We have two types of interventions. One was the antiretroviral, the other one was nutrition. Those are two different types of interventions. And the analysis will be separate. We'll see how to analyze these things. You may have different hypotheses, right? Because in the three-arm parallel, you are comparing mother HIV and mother antiretroviral against nothing, and the child versus nothing. So those are two separate analyses that you're doing because you have three arms. But if you had a three-arm parallel, you may compare an ABC, you may compare B to A, C to A, and also C to B. So it depends on your hypothesis of interest. Okay. Yes.
So I have a doubt whether incomplete factorial to be done in my patients, because in any sense we need to treat all our patients.
Right.
So is this the only ethical way for me?
There may be other ethical designs, but as you say, it is unethical to not give anything. So most likely you would have to do something. If you're contemplating a factorial, then you may have to do incomplete. But if you have a treatment that works and that becomes a standard of care, then you can do, then it's not a no-no, right? Then you can have standard of care versus new psychotherapy and standard of care versus another new psychotherapy and do that as a 2x2 factorial. Because then you'll be getting standard of care, yes, yes, standard of care and new psychotherapy 1, and standard of care and new psychotherapy 2, or both psychotherapies at the same time. That's the factorial. All right. So randomization is key. This is, if you recall what I said in the morning, if you don't randomize, you have a garbage study because you started off with a garbage sample. People will argue, oh, no, it's impossible to randomize, is this and that. So yes, if you cannot randomize, you cannot call it a controlled trial. You can call it a comparative study. So we're comparing this group to that group. The word trial should not be there because trial means experiment. You didn't control who got what. Some people got it. Yes, maybe you controlled it by allowing them to do it, or it was just natural that these people do it. So we will talk about those designs. Those are quasi-experimental designs. Yes, they got an intervention. Yes, they got an experimental thing, but you did not control who got what in an objective way by randomizing. So the whole point here is how much control you have of making the study as experimental as possible, right? Remember what we said, this is trying to do an experiment. So when we randomize, we have multiple ways of doing it. We have what's called fixed allocation schemes. Fixed meaning that you, before you start the study, you settle on which way you're going to do it. And you don't change it. You don't have the option of changing it in the middle of the study. Then we have, more recently, people are doing adaptive randomization schemes. And we'll talk about some of the adaptive randomization schemes. We also will have a lecture, I think tomorrow, on adaptive designs, which are much more topics on multistage. We'll talk about smart designs, etc. But let's look at first the basics of randomization and how we do it. So simple randomization, we have clustered randomization and restricted random allocation. So, well, simple randomization, I didn't even have a slide for it because it's that simple. Simple randomization is every person that shows up, you have them basically go to A or B, and there is no restriction on it. It's like flipping a coin, but you've actually flipped the coin before and created a randomization list and just done it that way, okay? The problem with simple randomization is that suppose I'm having 100 people and I'm flipping a coin before, am I going to get 100, in 100 flips, I'm going to get 50-50? No, I'll probably get 48-52 or 47-53. I won't get it balanced in numbers. So we have a way of making sure that the numbers come out 50-50. We call it blocked random allocation. And we'll talk about that in a second as we go on. But simple randomization is exactly that, flipping a coin or doing it on the computer as opposed to manual. Clustered random allocation is different. In clustered random allocation, slide, maybe better. Did I turn it off? Oh, that's okay. It should work. Maybe it stopped. See what happens. Sometimes you have to do it. So in clustered randomization, what we have is we have groups of patients or groups of people that are being randomly allocated. So typically we think of clinics, and we would randomize clinics to A or B. And so everybody that goes to a particular clinic gets A or gets B. We don't randomize within clinic. So we're not randomizing at the people level, we're randomizing at the clinic level. We do this often in studies that are based in the community, where we randomize villages. Studies, we did a study of children that are in schools by randomizing schools. We did a study that was looking at women that go to certain beauty salons. We randomize beauty salons to do it. So you can, factories, we've done factories, we've done, yeah, those are the things that I've been involved with. But you can do it in groups of people. These are not groups that you artificially create. These are groups that exist. People aggregated themselves and lived in neighborhoods, lived in villages, attended certain schools, or worked in certain factories. You do this when individual randomization is not possible. When we were doing the study on children, we wanted to see if getting children to be more physically active in school and eat better would reduce their values of cholesterol in their blood. But healthy children, how do we get them? You go to pediatricians, kids go there when they have problems. We wanted healthy kids. Well, do we go to their houses? Well, that takes a lot of effort to do. Where do children supposed to be? In school. So we go to schools. We talk to the principal, and the principal says, sure, but you cannot randomize one kid to this and another kid to that, or everybody gets the same thing, or you get out of here. So everybody has to get the same thing. So we had to randomize schools. And same thing in a factory. These were workers that it was a chicken processing factory in North Carolina. There's lots of poultry, and it's a horrible job, taking out the feathers off the dead chickens. And these women are underpaid, working, sitting for hours. And whenever they have a little break of 15 minutes, they go outside and smoke. So one of the investigators came up with the idea of, why don't we do some aerobic exercises during the break, and we'll have instructors and do this, etc. So some factories were going to get it, and some factories were not going to get it. And these sorts of things happen. Now, the problem with this is that the outcomes within the people of a cluster are similar in some ways. Why? Because they work in the same factory, because they go to the same school, because they live in the same village. There's a village effect, there's a factory effect, there's a school effect. And this effect is quantified by what's called a design effect. The design effect is a quantity that increases the variability in the data due to that correlation. Suppose that everybody was exactly the same, then the correlation would be 1. And so there would be, even if you study 20 people, you're studying basically 1. So you have to inflate the sample size and the variance. So there's a formula for it, and we'll talk more about it when we talk about clustered designs on Friday, about the impact of this type of design on how we deal with the power issues and sample size on Friday. So the 4 characteristics that distinguish it is that the unit is an identifiable group, socially, geographically, or other connection. We have a hierarchical structure, and the members of the group are nested within the cluster, and we only have usually a small number of clusters. And so when we randomize a few number of clusters, we don't get the benefit of randomization. Nothing is going to be balanced that well. And so this is a big problem, is that we don't have that balancing effect of randomization. So we'll see how people deal with it in a second. Another way of randomizing is more commonly done, and that's stratified. And stratified may be, in this case, by disease status. So people that are mild, moderate, and severe are first grouped. And then within each one of those, you randomize to A or B. That way, the distribution of severity in A will be similar to the distribution of severity in B. We do this all the time in multi-center studies, so that the strata there is the center. The stratum is the center. So if you have 3 centers, now we randomize within a center, and therefore the distribution of center effects is the same in A as in B. Now we can do stratification, but you cannot stratify on many things. So you can do on sex, you can do on severity of disease, you can do on age group, but now you have, how many groups do you have? So that becomes too cumbersome. So we do it on a few key things. One thing we commonly done, and maybe you've heard all about it, is blocking and permuted blocks. And blocking basically is done to make sure that Well, for many reasons, but one reason is to make sure that the numbers in A and the numbers in B are balanced. So the size of A and the size of B is balanced. It's usually balanced within small blocks, but you could do it on larger blocks if you want to. So it's a numerical balance across blocks, which gives you better efficiency from a statistical standpoint. If there is a bias in a secular trend, because you get in now less sick patients in the later recruitments, you get in more sick at the early. This way you avoid bias. And if you have small blocks, you don't. Now, what we commonly do now, and it's become standard, is what's called permuted block sizes. Because we now want to prevent you, the investigator, from guessing who is the next person going to. Because if I tell you the blocks are a size 4, and even though the allocation is blinded and the study is blinded, you know side effects. You follow patients, you guess, oh, so far I know there have been 2 people that have had nausea and 3 people have been randomized. So the next one is going to be randomized to the group that doesn't get nausea. So you're guessing. And to minimize the opportunity of you guessing and then manipulating who gets into that group, we do permuted blocks. So we don't tell you the block sizes. We use blocks of size 2, 4, 6 if there's 2 treatments. If there's 3 treatments, we use blocks of size 3, 6, 9. And sometimes we'll choose a block of size 6 at random, or a block of size 4 at random, and then a 2, and then a 6, and then a 6, 6, 2, etc. And the order of the block size changes. We don't tell you. Why? Because there's no reason for you to know, except to become unblinded. And so if you ask, we will say, why are you even asking? You should not even be asking. That's not your problem. We will do it, and then we produce the listing. Once the listing is produced, we hide it from you. That's called allocation concealment. In the old days, we used to hide it in little envelopes that if you hold them up to the light, you cannot see what it is, opaque envelopes. Nowadays, how do we hide it? On the computer. So you don't see it until you put in all the eligibility criteria of the next patient and you answer all those questions, and then a little pop-up says, this patient meets all the criteria. Have they signed the consent? If you say yes, you say, okay, now the patient will be randomized, and boop, out comes the patient number. That's it. You don't have a way of finding out what's the next one. But we've prepared the listing, usually with this permuted blocks and stratified accordingly, and hide it from you. Again, if you ask, I'll say, why are you asking? There's absolutely no reason for you to ask for this. Now, there is a concern that if you are doing, especially group studies, you don't have enough people, enough units being randomized, so you don't get the benefits of randomizing a lot of things. So you won't get that balance. So what has been done is what is called now optimized randomization. It's a further restriction. So for example, if n subjects are to be assigned, then we select all possible assignments. So this becomes large. So that if we had, for example, as little as 20 people being, or 20 hospitals being assigned, how many ways are there to take 20 and put 10 in one versus the other? This is 20 factorial over 10 factorial, 10 factorial. This will be 20 down to 11 divided by 10 factorial. It's a huge number. Billions, trillions, quadrillions. Whereas some stupid presidents across the world say gazillions. So that's too many. But we have fast computers now. So we have the computer generate all possible gazillion ways. Then for each way, I have some characteristics of the 20 clinics. So this study that was done, I'll mention it to you. This was done in Argentina and Uruguay on interesting topic of proper management of the third stage of labor. So those of you in OBGYN can tell me better. But basically, what they were finding is that there were a lot of unnecessary episiotomies and C-sections. And they said, no, if we have the obstetrics group properly manage the third stage of labor, then we can reduce that. So they have to train the obstetric team into that proper training to do that managed care. Well, once you're trained to do that, you're not going to be able to randomize a woman who's delivering. Oh, you've been randomized to get the adequate third stage of labor and you not. I've learned how to do it. How am I not going to do it on the next person? So no matter how well I'm trained, I'm not going to be able to not contaminate. So everybody in the clinic gets the training, and some clinics get it, some clinics did not. They had 24, so it's even worse. I think they had 24 and 12, so they had an even bigger number. But what you do is, can I make it bigger? This is my 8th grade teacher told me that once. And I gave her a magnifying glass and she called my father and took me to the principal. Anyway, so what you do is if there are important characteristics you want to balance, like the expertise of the hospital, the years or the volume of the hospital, the experience of the OBGYN nursing staff, the experience of the OBGYN physicians, the whatever, urban or rural hospital, etc. They figure out some key characteristics. And so they say, do it in a small number. So suppose I have small number, I have only, suppose I have 6 clinics only. These are the clinics. And I can have A, B, C in group A, so group intervention, and D, E, F in group control. How many ways I can do this? I can have 6 factorial, 3 factorial, 3 factorial. So that's 6, 5, 4, 3, 2, 1. That goes, there's 20 ways. So I would list all 20 ways of doing it. So I have A and B is here, C goes here, and D comes here. Or A, B, C goes here, and D stays here, but E goes there, and F. And I can do all of those so that then I have D, E, F, and A, B, C. If you go through that, you'll have 20 ways. Now I look at what are the characteristics of importance here and the characteristics of importance here. Are they similar or different? If they're too different, that's a bad one. Then I look at all of those and what we say, look at the one that gives you the smallest difference. That was called minimization. Minimization. That was what was originally proposed. Minimize the differences between those allocated to intervention and those allocated to control. The problem is this was proposed in 1974, and I've heard somebody was using it. Most people don't use it at all. Why don't they use it? Because you've minimized and you selected one allocation. The word randomization is not mentioned. You didn't randomize. So why are you selecting it? You purposely selected that allocation. Therefore it's bad. Study is out. We don't care. So what people did is they call it something else that has the word randomization in it, optimized randomization. What did they do? They said some of these differences are tolerable. Let's say I will tolerate this one, I will tolerate this one, I will tolerate this one, and I will tolerate this one. So 4 out of the 20 are tolerable. They're not so different. Now that I've restricted to those 4 tolerable ones, I will now randomly choose one of those 4. Optimize randomization. That's what these people did. If you go to their paper, it's really interesting because they say how many they calculated the number. It was really crores of billions, crores of crores numbers of possible ones. But they had the computer generate it and generate the difference between them and then select those that were acceptable and then randomly choose one. Fast computers enable us to do things that we couldn't do before. And all right. Yeah. Oh, confounders again. Okay. Yeah. Oh, well, no, yeah. Right. Exactly. So this is what, so those confounders are the things that you are trying to match them on and to compute the difference. Yeah. No, this is all a design phase. This is all a design phase. So you know what are potential confounders. So in this case, they had the past experience of the staff, the size of the number of women they treated, whether the hospital was urban, rural, etc. So they know these things, we would like them to be balanced. Those are potential confounders. So in the randomization, because they only had 24 hospitals, they wanted to make sure that the differences between those that got the intervention and got the control on the confounders would be similar at baseline. So then they did this optimized randomization. But yeah, if they did not do this, they would end up with one that by bad luck was not balanced. So they got as balanced as they could on known confounders. So I've seen this done commonly in cluster designs because we have fewer units being randomized. When you randomize on individuals, usually you expect that things will balance out. If you do more than 100 people, well, actually, you need to do around 500 or more for things to more or less balance out. You still may get bad luck, but it's less likely to have bad luck the larger your sample size. Yeah. Yeah. So another word for this is covariate constrained randomization. It's exactly the same thing. But yeah, you can tell us a little bit. Mm-hmm. Yep.
We have a cluster RCT. The total we have 102 slums, which are our clusters in 2 states. One is Delhi and one is Hyderabad. And in our previous cluster RCTs, we used to do the line listing first and identify our screen high-risk participants, and based on the characteristics related to the slums and participants, we used to randomize the clusters. But in this one, we didn't have that liberty. So we used some assumed confounders, as we suggested, and we did our randomization in phases. So we listed down, we screened around 9 clusters at one time. We found few characteristics, and then based on those characteristics, like WHO and 5 scores and those few variables, we tried to minimize the difference, and then we randomized in 3 batches. So those were the 3 arms. So minimizing that difference
is this.
had some
Right.
of this background.
So that's covariates constrained.
That's covariate
randomization.
because we are using some features
Right.
of participants
this
and
is what-
few of
yeah.
clusters.
But you had it of participants as well as of the cluster.
Yes.
Most of the time, these are done with characteristics of the clusters because you don't have the participants
Yes.
available yet.
So that could have been the case if we were doing the randomization before our screening.
Right. You already had screened, so
We
you had
screened them.
information.
Yes, but we couldn't screen all of those participants, 102 cluster at one time. That's why we planned it in batches.
Hmm.
And it was just idea which we suggested and initiated it.
Mhm.
So she is unblinded statistician in that study. So it's still going on. We are in
Good.
our last phases. And
So it's
the
an
same
interesting study because most people don't have that option
Yes,
of using participant information.
yes. And
They
this
only
is
have-
the same study about which I was talking to you about loss of cluster.
Okay.
So this is not the loss to follow up of the participant, but the loss to follow up of a cluster
Cluster,
itself.
yeah. So,
This
so
was the same.
when we talk about clusters, on Friday, we'll talk about the importance of the sample size and also of inflating the sample size for losing clusters, because we also inflate for losing participants. But when you lose a cluster, you lose a bunch of participants because you lose everybody that's in that cluster. So that's also a big concern.
More than the participant, it's a problem of the loss of power.
Hmm.
So if it is individually randomized trial, if you lose few participants, you don't lose that much
power.
of power as in cluster RCTs.
Right.
So that's actually our primary concern.
Okay. Yes. So stratification is another restricted randomization technique, but it's not as restrictive as this one, right? So there you take in, here you have the option of taking many characteristics, many potential confounders. Stratification, you take a few key essential ones and you still allow all possible things. Here you only are taking one for its much smaller subset of potential allocations than that. But you know them beforehand. While in stratification, you don't know beforehand who's going to fall into which one of these. Okay. All right. They're the same. They're just called different. I should have put also known as covariate adjusted randomization. So they're the same. It's just in one textbook, they call it optimized randomization. And these people in that paper call it optimized randomization. And other places, they call it covariate adjusted randomization, but it's exactly the same. Same technique. All right. So enough on randomization. We can take a break here. Is that? Or you want to do the ethics part? No. It's you decide. Okay. Take a small short break and then we'll do ethics.